So once again, welcome to Virtual Care 101 for Child and Youth Mental Health. It's a beautiful-ish afternoon here in Ottawa. I hope you're all doing well wherever you are in the province. My name is Purnima Sandar, and I work at the Ontario Centre of Excellence for Child and Youth Mental Health, and I'm really pleased to be co-hosting this session with Dr. Kathy Short and colleagues from School Mental Health Ontario. You know, in early conversations when Kathy and I were speaking about the impact of COVID and the situation right now around care and needs for care in the child and youth mental health sector, we talked about how we've been talking for many years about the opportunities and potential for working in a virtual way with families. And now we've moved to a stage from we can and we should to now we have to. And so we're really, really pleased to be able to rely on our friends, our panelists today, who will share all of their expertise and knowledge about how to do so in an effective way and to support the mental health needs of kids and families, whether they are working out of community-based settings or a school setting. Maybe Kathy, I'll invite you to say a few words as well.
Yes, hi everybody. Thanks so much for joining. I wanted to just say a warm thank you to Purnima for her partnership in putting this together, and to the panelists who will be joining us today to bring their expertise, and to all of you for making time for this important work that we're all endeavoring on together. For those who don't know, School Mental Health Ontario is a provincial implementation support team, and we are designed to help all Ontario school boards with student mental health. And most relevant to today's session, I'd highlight our efforts to encourage and scale mental health promotion, prevention, and early intervention services and supports. So you probably know, or you may know, that we often work in collaboration with other intermediary groups like the Centre of Excellence, and we've found even more reasons and benefits to working together during the COVID-19 pandemic. There have been new opportunities and ways of working that I think really present themselves, and I think we're all trying to take full advantage of that at this difficult time. One of the things I'll just highlight is that we are today offering a very high-level virtual care 101 in Ontario, but we're looking forward to continuing to collaborate together and with all of you to meet ongoing and deeper knowledge needs over time. So we'll look to you for your feedback so we can be responsive to your needs along this journey. Purnima, back to you.
Great. Thanks, Kathy. So just in terms of a very broad overview, as Kathy said, this is a virtual care 101, so fairly high level. We've structured the session to address both process issues and pragmatics, so the practical aspects of delivering virtual care, as well as a number of the clinical considerations that you'll want to keep in mind as you deliver care. What we will cover, again, is sort of this high level, but we won't be covering specific platforms like Zoom, OTN, et cetera, et cetera. There are a number of platforms out there, and as people are exploring them, we understand that people have needs around specifics, and this particular webinar won't focus on that, nor will we focus on particular guidelines as per your professional designations or organizations. And so we'll leave that to other resources and so on, which we have a number of at the Centre of Excellence. And so we'll direct you towards that resource and all of our specific tools that we've assembled to support virtual care delivery across the province at the end of the webinar as well. In terms of French, again, thank you for submitting all of your questions. There were many that we went through, almost, I would say, over 2,000. We did invite questions in French, and we are fortunate to have two of our panelists today who are francophone. The webinar will be conducted primarily in English, but they will be responding to several of the questions in French. But all of the information that's shared here today will be rolled up into a resource that we will make available in both official languages. And again, we'll direct you to where you can find that at the end of the webinar. Again, there will be a recording that's available as well. So if you didn't catch, or if you had, sometimes I have visitors drop in while I'm in the middle of working. If you miss a portion, don't worry, you will be able to catch up again because the recording and the resource will both be made available to everybody. So with that, I will turn it back over to Kathy.
Thanks. So we're going to go through 5 categories or theme areas based on the 2,000 plus questions that you all posed at the time of registration. And we're going to begin with Ghislaine and Veronica, who will be helping us with orienting towards virtual care. So turn it over to the 2 of you now.
Thanks, and good afternoon, everyone. So let's look a little bit about the term of virtual care and what it encompasses. And it's really all about the ways people can use digital tools to communicate in real time through video, messaging, texting, apps, and the good old telephone. Depending on your role and organization, you may need to evaluate the services you offer and decide what can and cannot be delivered as continuing virtual care while taking into consideration client needs and safety. So if we're looking into the differences from usual face-to-face care, client-provider relationship and professional.
Can I go behind you?
Yeah, I'm not on.
Sorry about that. It appears I've been muted. Just a reminder for everyone to please mute your systems. I'm not quite sure what you were able to hear, but in terms of relationships and professional relationships, it's really identical to face-to-face encounters, which my colleagues will discuss further. For many of us, we've been pushed out of our comfort zones and having to do things differently. It will take more preparation to determine what technology is available to your client and explore your comfort levels to build your therapeutic relationship virtually. And really, a session can be anywhere from 30 minutes to 1 hour or more. And I will leave that up to you in terms of your clinical judgment. Virtual care was occurring way before this pandemic took effect. The difference is that we all have been forced into it, willing or not. Think of the Kids Help Phone, Bounce Back Ontario, Anxiety Canada. These platforms developed online self-help interactive modules, tools, and evidence-based resources. I strongly invite you to check those out. To you, Veronica.
Thanks, Ghislaine. So in setting up for virtual care, there are some logistical pieces to consider that will help with your website manner. The first is making sure you have the right equipment, testing the equipment, and familiarizing yourself with how to adjust the settings on the fly. So for example, having a screen that's big enough to see the client or patient's face well, good quality headset and microphone so your voice is clear. The second is setting up your physical space. So you'd want to consider a room with a door to eliminate excess noise and also make the patient or client feel like they're in a secure private space. Optimize your lighting. So being aware of how lighting can change, like on dark and cloudy days. And if you're in a room with a big window, make sure it's not behind you because it does change the way that you appear on video. And open up the virtual platform that you're using in advance. So when you're setting up your space to see how it appears on camera. In terms of preparing yourself to deliver virtual care, think about your already existing patient or user-centered approaches and how that can translate to website manner. If you have the time, practice until you get to a comfortable spot, team up with colleagues to help each other prepare, and make or use an existing checklist for yourself if you feel like it might help you organize better. So I'll hand it back over to you, Ghislaine.
So in order to look at practical steps, I have been coordinating CHIO telemental health consultations for the past 13 years, and our consultations were always done in room-based settings, such as hospitals or community child and youth mental health agencies. Now that we're connecting into the family's homes, there have been a few situations that have led us to create an etiquette guideline for the families. Again, this is in the context of safety and ensuring privacy. If you do have no-shows and cancellations, I would say approach it with a trauma-informed lens. What happened? Maybe the internet went down. Maybe dad is in a really important webinar with the 1,000 participants and he needs all the bandwidth, so he kicked off all his family members. Check in with a phone call, kind of see what's going on. So we'll move on into ethics, privacy, and legal issues to consider when delivering virtual care. I will start with this francophone question and then I will move into the English version. Comment obtenir le consentement pour les soins virtuels? Il n'est pas nécessaire de développer un consentement spécifique pour les soins virtuels à moins que votre organisme décide autrement. Un consentement est quand même requis et peut être obtenu pendant un appel d'admission et noté au dossier avant un contact par écrit tel un courriel. Vous avez certainement un processus en place et je vous encourage de revoir vos politiques et procédures de votre organisme. Pour mon service, il y a eu un impact sur un consentement signé qui était obligatoire et nous devions trouver une solution digitale, ce qui m'a amené à créer une fiche de conseil pour avoir une signature digitale à l'aide d'un téléphone ou une tablette intelligente. Back to English, how do we obtain consent for virtual care? There's no need for special consent that is specifically related to virtual care unless your organization has decided otherwise, but consent is required. Usually, this can start with a telephone intake call where consent is discussed and noted prior to written communication, such as emails. Again, you may have specific processes in place, and I encourage you to review your policies and procedures. What has impacted me is that for telemental health referrals, a written consent is required. We had to go digital, and it led me to come up with a tip sheet on how to use smartphone or tablet and use the markup function to create a digital signature. On to you, Jose.
Merci, Ghislaine. I'll talk to you a little bit about privacy. So there was a number of questions around privacy, and two major points around privacy is that the virtual care platforms or the tools to provide care are really important to consider. And some have gone through rigorous security, privacy, and risk assessment, but others have not. So using tools that meet privacy standards may have some built-in consent processes, so that's one point, but other tools you will need to consider how Ghislaine has just described. Obtaining the consent and really documenting. This is something that we've been repeating for the last 6 weeks on a number of occasions to our providers. Obtain consent, document the consent. So many of the regulatory bodies that maybe you belong to have provided some language to their members that you can use as part of your documentation. And even in the context of COVID-19, there's been a lot of guidance at the ministry level even offered to our providers that everyone is acting in good faith right now through maybe everyday communication technologies giving the public health emergency. Again, obtain consent, document, and that all will be good. The other part of the privacy that I want to touch on is the one that touches to the delivery of care in people's home. So there was questions around how can I make sure that other family members maybe don't overhear the consultation or the appointment. So many homes have listened to best practices and have set up technologies and computers and shared spaces. And that is really good practice. And I think it's important that you let families and parents and caregivers know that this was a really good thing that they did. And now in the context of trying to do an appointment maybe with their teens, that they might consider looking at creative ways to use a private space. So a lot of things that we're using right now is we're encouraging kids to use headsets, maybe go into a private space within the home and do in the garage. We've seen people in the car, not the running car, a car that is not in motion, but just be creative with them and finding spaces where they can participate in the appointment and still feel they have some privacy while they're discussing things with you. So that would be really important. And one other thing I think Ghislaine touch on, and you may hear from other panelists, for us, we've been able to really provide guidance by providing an orientation letter. So something that you can give to families to prepare them for the appointment. The preparation in virtual world is really, really important. Another question in this category was around professional boundaries. So I think that it's really, really important in the virtual world to manage expectation. Many of the platforms have you available 24/7. People can see when you're online if they're on different platforms, and certain platforms such as social media can sort of create confusion around the relationship between the provider. So I really encourage you to have clear guidelines on how you want to establish the care that you're going to provide and make that explicit to your clients, and they will be able to trust that. I'll move on to French a little bit because this piece is really important to me, so I want both languages. Je voudrais juste parler un petit peu des limites de la relation professionnelle. Gérer les attentes lorsqu'on donne des soins virtuellement est super important pour moi. Donc, établir des règles pour améliorer son efficacité professionnelle, mais surtout pour minimiser la confusion avec les clients, les étudiants. Il y a l'utilisation de certaines plateformes ou des réseaux sociaux qui affichent lorsque vous êtes présent. Donc, les gens voient une petite lumière verte. Ah, José est en ligne, peut-être que je peux lui envoyer un petit message. Alors, d'établir des lignes directrices avec les clients et les étudiants vont vraiment vous permettre de garder les limites professionnelles en place. now back to English. There was a lot of questions around documentation and record keeping, and I'm going to share that portion with my colleagues. And the one thing that I want to say is that you would continue to document in the same way that you're typically documenting right now. The only advice or recommendation I would have is that if there are any issues with the connection didn't go well, or there was, you don't feel that you got a good assessment, that you would document that as part of your regular documentation. But over to you, Aizen.
Thanks so much, Jose, and welcome everybody. Yeah, in terms of documentation, I think most of us are working with agencies, institutions that would have documentation requirements, and they don't change if we're working in the visual or the virtual world. In terms of a typical session, what are the things that I typically document? Certainly, I would document the method used. Are you using Zoom? Are you using OTN? Are you using the telephone? What devices are being used? I make a point of documenting the start and stop time. Sometimes that's important in terms of if there's billing for services, they're often time-based, and documenting that is important. I make a point of documenting who is in attendance, both on the near side in terms of whether it's myself and perhaps other folks, and at the far end in terms of the client that you're working with, and if there's parents or other providers involved. And I ask them to clarify what their roles are, and I document what everyone's roles are. As per any usual session, you would document the typical content, what is discussed, what are the topics, what are the issues, etc. I make a point of also documenting kind of process issues, particularly in terms of what was the comfort level that folks at the other end had. Did they feel uncomfortable? Were there other concerns about the setup they had? Are there any issues or concerns there? Certainly, it's not uncommon for there to be technology issues that may pop up, and I make a point of noting those. And when we do our telemental health assessments, we have a process by which we're able to capture if there's any issues with technology that, if they're persisting over several sessions, then we might want to be following up with our technology providers about these things. So fundamentally, most sessions that we do are not really going to be different in terms of documentation than you would do face-to-face, other than documenting some of the technical aspects of it. All right, I'm going to now move on to another section, focusing a little bit more on sort of confidentiality. In terms of confidentiality, again, most organizations, most people joining in today belong to organizations that would have expectations and procedures and policies around maintaining confidentiality. Things to keep in mind when you're doing it virtually. As was mentioned previously, we develop a sort of a tip sheet that we put forward in terms of our usual practices in doing our best to maintain confidentiality. When I'm in session with folks, I keep in mind confidentiality issues on my side. Can I reasonably say that my room is private and I'm able to have a discussion in confidence with privacy? The setup of the room is such that there aren't people who are, can look in a window, or people can walk through the session in the middle of my conversation, etc. Sometimes I'll actually kind of pan around the room to show folks that are in what does the room actually look like, in case they have any questions or concerns. And I go through that same process at the other end in terms of reminding people around basic strategies around maintaining confidentiality. Often in the session, I may say to folks at the beginning, jeepers, I might want to have a conversation with one person stepping out so I can have a bit more of a private conversation. Would that be okay? I obtain consent for that to be able to happen. And of course, I would also document that consent along the way. All right, I'm now going to hand things over to Michelle.
Thanks so much. And so just good to meet with everybody today. And one of the questions that had come forward was, how do I address that first meeting when I'm with the client? And really that's a critical first step, just in terms of the stage that you set with them. But we're both in potentially less comfortable situations, both the client and ourselves as therapists and engaging with our clients. And so we really need to be relaxed about any techie mistakes that might take place. One of the first things that you'll want to ask them is, how do I contact you if the video or the phone isn't working? And that's going to be an important reach out, and for them to feel assured that somebody's going to reach out to me if something doesn't work or if our call gets dropped. I think one of the things that we'll want to do is just really be comfortable with the amount of time that it takes just to become comfortable with a platform. I've heard some individuals say that while they're using an agency specified platform, that some of the clients are saying, well, I'm more familiar with Zoom or Skype, couldn't we use that? And sometimes we forget that our discomfort comes from not being familiar. So is there a way to interact in a non-rushed or really fun way with the client in terms of just checking out the different components of the platform that you're using, asking them to click on different things? You're going to show them different things. And if you don't feel that pressure or that need to move into the clinical session in those first few minutes, or maybe even the first half of that first session, it will take you a very long way, and just ensure that future sessions will be more successful. Taking that time to ensure that your environment is comfortable is really critical. In an office setting, we've already set up ahead the seating, the lighting, making sure the ambient sounds are welcoming, and it's exactly the same thing with virtual. We have a little less control over some of those things, but what we need to do is make people feel comfortable. And so again, with this being so new on both ends, sometimes just taking the time is critical. Safety and trust are important. And for each client, safety and trust is going to look different. It'll be really important to explicitly ask them, what does it mean to you for this to be a safe session for you? What is trust going to look like in an online format? And not assume that we understand what that is, and to really spend the time just to listen to them. And that really shifts into another question that had been about, how do I build a virtual therapeutic relationship with my client? Research identifies the importance of that therapeutic alliance, even beyond the psychotherapy, and being with your client is critical for them to believe that you're actually listening to them. Is somebody quiet? How do you engage with them when you're not literally in the room? But it might be, depending on their age, have them share a toy, a photo, a favorite song that they have, doing something that would engage with them, that lets them know that I have the time to listen and pull you into the conversation. If you need to draw them out, you might ask them what they want to share with you the next time. You really want to set them at ease and ask them if they have any questions. Have they ever done anything like this before? Maybe that they're very comfortable, because our youth these days are on these platforms so often. Is there anything though that might make them nervous? Is there anything in terms of their meeting with you that they might be unsettled about? If they want to make sure you're alone, be prepared to pan the room for them. So while we make sure that what they can see behind us is safe, if they're really concerned about, are you truly alone, we need to make sure that 360, it's okay for us to share our room with them. If there is somebody else in their space, acknowledge that with them and maybe ask them, is that okay for you to have somebody else in the space? Is there any way that you want to make the session private? They may not care. They may want to introduce that other person. The part that it's going to be a little more difficult is if they seem a little bit nervous, or if there's somebody in the room that they don't want to, but they can't actually say that. You may need to help problem solve with them different ways that if in the future they want to make it private, they may want to bring some earbuds. Your platform might allow you to use a whiteboard. There's the chat option that we're even using. So while you're having conversation, you might want to chat with them just to engage in a couple of private questions to see how you can further make the session really robust for them. I'm going to transfer over now to Sinsu. Sinsu, you're just on mute.
Thank you. So that's one of the virtual care I always forget, and I need help. So, so one of the questions that I'm going to be addressing today is how to deal with youth with complex issues. So what I would say is not everyone can tolerate a virtual care. I have patients who have high anxiety over video, over phone. Like how Jose was mentioning, to even before the initial visit to sort of establish, the limitations of the virtual care, for allowing the patient and the caregiver to determine if it is suitable for them, would be the first step. The second step I take is, at the beginning of each visit, I will establish a very attainable goal. And if I know that, for example, a physical exam, I cannot do that, or vital signs, I cannot do that. And if they are expecting all those kind of things, I will say maybe that requires an in-person visit. So therefore, I will establish the goal for the visit. That would be my second thing. And then the third thing would be, I try to be as flexible as possible as how I would be in an office setting. So I have patients with ADHD who want to just run around the room. I just let them run around the room while I give the caregiver collateral history. And when they are able to sit down and talk to me, and that's fine. I could talk to caregiver on the phone while I see the kids virtually, or vice versa. So just being flexible is very important, and just change the care accordingly, according to your patient's need. And with that, I'm going to hand it over to Hazen to discuss about clinical consideration and virtual care modalities.
Thank you, Sindhu. So there was a few questions in this particular domain I'm going to try to address. So one of the first questions was, are there particular therapeutic approaches or modalities that are best suited for virtual care? And I would say, any kind of talk therapy in which you're able to engage another patient in conversation is helpful. So whether that's motivational interviewing or supportive psychotherapy, there's a whole bunch of modalities involving talk therapy that can be very helpful. To touch on Sinthu's experiences, I have a few experiences with kids who might seem difficult to engage initially. But again, if you're flexible and you're patient, many kids who may come into the session not interested in speaking.
No, that's going to break. Okay, pull it out from underneath, please.
If you give them time, they will actually engage, and they can make a very good use of the time virtually. There really aren't significant barriers. Obviously, if there's kids who have difficulties being able to speak, etc., speech difficulties, if they are hiding in the room, these are particular challenges that often you can work through even in an individual session. There was another question about group work, and certainly working virtually, you can do group work. If you have a group of folks in a room and you are sort of facilitating at distance or virtually, you're using the same kinds of principles of group therapy as you would if you were all in the room together. Sometimes it is helpful to have a kind of a co-therapist in the room who may be able to draw your attention to particular issues or manage particular issues that might be difficult to do it if you're doing it at some distance. In the current pandemic situation, oftentimes we may have a group together as we are now, all kind of sort of individually situated. Can you kind of run a group in this domain? You can. You may have to limit the size because, as per this session, I can see a few folks, but obviously I can't see everybody. And it would be probably advantageous to be able to see everybody that you're working with in a group type format virtually, so that you can be attending to what's happening. It's also a bit more difficult in that frame to be able to attend to other things that may be happening. Are they showing other signs of anxiety or distress non-verbally that may be difficult to pick up if you're doing it virtually. But it's certainly possible that you can do it. There was another comment about what about single sessions, and I would say my experience in doing consultations, certainly for a general consultation in my specialty in psychiatry, In a single session, you can certainly gather all of the information required. You know, Sindhu pointed out, you know, sometimes kids with ADHD as an example, they don't have to say a word. They can come in the room and they can bounce around the room, and you can have all the information just in their behavior to be able to help you in assisting the diagnosis. So there are not significant barriers in terms of being able to gather the information that you need in a single session. All right, with that, I'm gonna pass this back to Michelle to talk a bit about, or sorry, back to Sindhu to talk a bit about safety and support.
I actually unmuted myself, very proud of myself. And so thank you so much, Hazen. So I think I'm addressing two questions here. The one is, how do we know that we are not missing any facial cues and expressions and things like that? So I think as providers, we rely a lot on sort of that establishing the rapport and being with that patient and being connected. Example, like handing a tissue box to everything. It matters to us a lot, and that's how we trained. So even in the beginning, when I tried to do this, I have to tell you that my biggest barrier was that I am not going to be able to do a good mental status on my patient. I'm not, I'm not comfortable, and that was a barrier for me. But since I was a resident, I was forced to do it. So then that actually got me comfortable to say, hey, this is not too bad. So now I'm very comfortable. I don't even notice the difference. And studies show that most of our information that we need to provide good care for our patients are actually auditory and visual, which we both get through the virtual care. So in that case, we are able to do that. The second thing is, I also noticed over the years, the video quality has improved so much that, you know, I mean, it's actually better, because staring at the person for a like straight 1 hour, it's very draining, you will see, but you get to know every single thing that they are doing, just because you're not too much distracted by anything else that's going on around you. So my sort of spew on that is, as long as you are going to sort of keep doing it, it just becomes a practice and you just get used to it, is how I would say. And the other thing studies also show, which Hazen already mentioned, is that you can have like another person either with you or with the patient, and they can actually point toward the cues, or the interactions with the patient and the caregiver can actually give you a lot of different kind of informations as well. The second topic is the safety that I'm supposed to talk about. So what I would say is, whenever you are scheduling a visit, right off the bat, make sure that there is an available responsible adult for that patient, who is either available via phone or they are physically with the patient, so that if in case of emergency, they can take some action. Say if the patient does disclose their safety risk, but you establish that, hey, you can stay safe until sort of the next visit, involve that other person, make sure you do a safety plan with them, also provide them with the resources such as crisis line, and if symptoms do get worse, to go visit the emergency room. If there's an immediate danger, you keep the patient on the phone while you're making the call to 911, and also possibly involve the caregiver at that time as well. If you notice that there's any abuse, you're suspecting that there's any abuse of any kind of those things going on, what you would do is, you will do as you will do in like a normal visit, where you will contact the child protection and they will do their investigation. And now we can also like do form 1 through virtual assessments for if you are a physician. And with that, I'm going to hand it back over to Hazen again.
It might actually be to Michelle around
Michelle, oh, I'm sorry. So as you can see, this is what happens to me during a virtual visit. I get confused too.
No, we can interact together, which is great on this kind of a platform. And so just one of the questions that had been asked was with respect to differentiating supports. And was virtual contraindicated at all? And I would say the times, similar to what some of our other presenters have mentioned, that we always need to ensure safety or privacy concerns. We know that the use of women's shelters has decreased. We know that the number of crisis calls have decreased. We know that the number of child abuse requests have decreased. So we know that many of our previous concerns have gone underground and are silent for this period of time. And so it will be really important not to rule out virtual, but to be aware that in the engagement of virtual, that I may need to be really just very sensitive to the safety and the privacy concerns, both for confidentiality, but also because we may be dealing with some at-risk home environments. And so that's always something not to stop doing the virtual, because we may be their one window into enabling a greater sense of security and safety, making some safety planning, or their one opportunity to show some of their nervousness that we might want to gauge, and then see how we might want to work with them to move into a place and doing some planning where they might be able to have increased safety. Another thing to consider just in terms of, is virtual contraindicated? If a client is struggling with paranoia or significant anxiety where they believe they're being listened to, then again, instead of saying, I shouldn't use this modality, to be asking them, how can I be with you? How can we meet while we're needing to do this more online in a way that leaves you feeling more safe and more secure? How can we reduce the anxiety that's there? There are going to be situations where it's difficult to manage the dysregulation of somebody else in the room. And so just in those situations, well, in the past, we may have been able to meet with them one-on-one. We may want to ask if there's another sibling or another caregiver in the home that can be with them, even just to be in the room, that may give them the ability to regulate their emotions just a little bit better. Again, it's going to be on a client-by-client basis, and as we listen to them. I do find that it's harder to read some of the nonverbal. You can't see somebody's fingers drumming on the table as a sign of agitation. You can't see that knee being bounced up and down to see that they're becoming a little more anxious. And so it's going to be important, although to our benefit, we're seeing faces. And so it's going to be really important to read those cues in terms of the eye shifts, in terms of how they're taking a breath, whether they're slightly moving back, and to start to learn to read cues that maybe we haven't paid attention to as much before. The other consideration to make is that it may be difficult to say something that's a little more difficult and then just hold the space. There is something to be said about the presence in a room, but again, it's our comfort and our being familiar with something versus making that a determining factor that really should contraindicate our use of virtual. The other thing to consider is, when are the faces grainy or sun-washed? I'm even aware of my own face. I sit in front of a window and suddenly realized at the last minute that the amount of light coming in today really makes it different. But in those situations when a face is so washed out that you can't see that, then you might want to ask the client or the other person in the room to move to where you can actually see their faces better. Always use your clinical expertise to help shift the environment just to be responsive to those clinical needs. And ask yourself, is it my concern? Is it lack of familiarity? Is it that of the client? What would cause me to have that caution? It's interesting, somebody had asked, is virtual preferred? And I would say it depends. We are running some groups for neonatal and prenatal mums. It has been really difficult over the last year to year and a half to get the number of mums out. We've actually seen those groups double and triple in size by the removal of transportation. So they're actually finding it easier to meet while they're in homes. And so that was something we would never have imagined. All groups, in fact, are increasing with transportation no longer being an issue. In the evenings, we're in a very much rural area, as a number of you might be as well. And so transportation can be a limiting factor, and it's really making all people equal. And so that's been a real pleasure to see that. One of the other questions that have been asked is, are there different considerations for different diagnoses? Instead of answering that explicitly, I would say, see this as an opportunity to keep asking your clients how to make the service better. I think it was Sintu who mentioned that just as with ADHD, we might have permitted them to run around the room while they were in our office. One of the benefits is that for groups of children, that might have set others off and it might have been more difficult to manage the space. Now those very rambunctious children are in very separate spaces. So we might be able to see them moving, but they're not bumping into each other. And so it becomes an opportunity. And again, whether it's clients with anxiety or depression, see that as an opportunity to keep asking them how to make this better for them and to continue to learn as we're engaging with them in their new spaces and in our new spaces. Hazen, over to you at this point.
All right, thanks, Michelle. So a question was asked about how do you get comfortable with delivering virtual care, and what about troubleshooting technical issues? So I was asked to comment on perhaps some, do's or don'ts to keep in mind. So one of them is to stay positive. So I'm just going to focus on the do's versus the don'ts. And they're really very practically oriented. It's helpful, it's important to be prepared for a session. If you're going to be using materials, if you have to access information, make sure it's readily available so you're not having to kind of shift your attention from engaging with your clients to having to look on your screen for something else. Staying engaged takes a bit more effort and a bit more energy when you're working virtually, and distractions can impact that engagement very quickly. Helpful to be on time, because if you're not on time, then you find yourself feeling rushed, and often when you're rushed, you start to make other kinds of mistakes that compound the difficulties. As was mentioned earlier, really important to check and adjust the cameras and the microphones at the start of the meeting. I always take a moment to sort of say, look, I'm going to check my settings, make sure things okay. Along the way, before we get started, I might say we got to adjust the microphone volume, going to change, going to get people to move around a little bit so I can get everybody in the frame. Doing that up front is helpful because to do it in the middle of the session sometimes can be a bit disruptive. Always make a point of talking about informed consent and talking about confidentiality up front before you start the session. Always make a point to introduce yourself and anyone who might be with you, and make a point of going through introductions at the other end so that you can ensure everyone else is included. Take some time to explain sort of the purpose and the structure of the session so that people have a sense of what's going to take place. Often in sessions, people might come that you don't know before. Someone walks in and wants to participate. Take a moment to do the introductions as well to make sure that they're included. This is really sort of good attachment behaviors that helps people feel welcomed and engaged. In the same vein, if someone is leaving, take a moment to say thank you so much for joining, etc., and make it a more formal goodbye. If in the middle of what's happening, you're seeing something that seems a little odd or unusual, pause and say, is there something going on? And the example that I give about that is I did a session with a family, and throughout the session, there was these odd looks between them, and they were kind of, there was something going on. I couldn't figure it out. And then at the end of it, when the camera switched back to the self view, all people could see was just the very top of my head. And the whole session was spent with me only showing the very top of my head. And they didn't know that they could sort of stop and say, Dr. Gandhi, there's something wrong here. So if something odd is happening, take the time to sort of check it out. Also, if in the session, there's either technical difficulties, there's difficulties with hearing, or there's paper shuffling, or you're not able to hear things, sometimes the polite thing is to kind of, be polite and nod and make it look like you've heard things. But if you can't hear it, stop it up front and say, sorry guys, I can't make it out, because often you can go many minutes where they're talking thinking that you understand them and you don't. And to then backtrack to say, well, can we talk about the last 5 minutes because I didn't really hear it? It's better to sort of nip that in the bud up front. Helpful to manage your time. Make sure that you have enough time to kind of wrap up the session and close the session. In the work that we do, our sessions start automatically and end automatically. And sometimes if it gets close to the end, we get cut off and we don't have a chance to properly say goodbye. And that's important. Throughout the session, it's important to model positive behavior. I would say You have to mind your inside voice. Sometimes when there's technical difficulties, issues, you can get a little frustrated. Important not to demonstrate that, because if you're demonstrating frustration with the technology, you're giving permission for them to also feel frustrated, and that can change the tone and the sense of how things go. There's always going to be some technical issues or things that don't quite go the way you planned. It's important to be patient and to stay positive, and to be persistent. Most of the issues will work themselves out. And staying engaged with your clients throughout the process is really important. And if you follow those basic do's, over time, you're going to develop the skills to be able to do this very effectively. All right, I'm going to pass things over now to Ghislaine.
Thanks, Hazen. So we're going to talk a little bit about some of the most common technical issues that can arise and how you can handle them. In order to handle these tech issues, it's okay to play with the technology and test run the platform that you'll be using. It's a learning curve for everyone. Nominate a team member, a closet techie who can do some practice runs with you, provide you step-by-step instructions. Perfect time to test your equipment and your microphone so you don't sound like Darth Vader. Get the two-sided view. What is it like to be the one receiving the call, and what is it like to make the call? It's a perfect time to test the buttons and play with the settings to familiarize yourself. You know, last week I had a test call with Cynthia, and instead of muting herself, she hung up on me. What are we going to do? We're going to laugh about it, because these are the opportunities that you're going to learn about. Issues are going to occur, whether they are human errors or technology failures. Calls are going to freeze, they're going to drop. Best to work out a plan on what to do when that happens. Your client is unable to turn on the camera, or his audio doesn't seem to be working. How can you make this work? Remember that we're all doing the best that we can in these extraordinary circumstances. And sometimes it may be the push for you to think outside the box. Be gentle with yourself. Laugh about it. We're all in this together. And to be quite honest, a lot of these kids and these teenagers, they are the ones who are going to be helping you figure out your system before you're the one helping them figure it out. So it is what it is. There will be things that are not in your control. Ontario is a huge province with significant discrepancies in terms of quality internet coverage. The reality is that some families cannot even do online banking with their internet, or that families do not have the means to have a device. Phone consultations may be your only option. Let's not forget, you're not working from home, you're at your home during a crisis trying to work. We're all in this together. So we're going to move on to our one top takeaway. And I can get it off started, and then I'll name the next panelist, and then we'll kind of move on from there. So my takeaway is we're all in a learning curve that's going to push us out of our comfort zones. I'm going to move it on to Jose.
Thank you, Ghislaine. I've actually changed my top takeaways, and I apologize. I have more than just one or two, but I think I'm going to stick because of this morning experience I had, because that's closest to me. Be prepared, be patient, and just willing to try this. I had a call this morning of one of our psychiatrists who was trying to assess a patient in crisis, and the first platform or the first sort of standard work didn't work. So what's next? And he was patient, he was willing, he was prepared, and we made it work. And it makes a whole world of difference to actually the family and the patient. And I think if it doesn't work out, just have a plan B. But really, be prepared, be patient, and be willing to try this. Over to Veronica.
Thanks, Jose. My takeaway would be what Ghislaine had mentioned in terms of finding a colleague or a buddy that you trust, and try it out, test it, adjust, and try again. And the more comfortable that you get, the more comfortable you'll come across when you're in your sessions. I'll hand it over to Cynthia.
And as for me, as you can see, I'm needing a lot of help even during this session. And just like how Ghislaine described, I'm always needing help, and I have been doing this for a while. So I have learned to laugh at myself, and I don't take it very seriously. And yeah, so I would say it's a different platform than in-person visit, and you just cannot be, you have to change your style and adapt to the difficulties that comes with the virtual care. So I'll say, just laugh it off. And I'm not too sure who's on the line for me. Hasten, go ahead.
I'll pick it up. My two takeaways would be yourself and trust yourself. Trust your clinical expertise and your assessment skills, and appreciate that this is a vehicle. You don't necessarily have to try to do things differently or act in a way that's uncomfortable, hoping that somehow that will make things better. You're good at what you do. Stay with those skills. Trust yourself and be yourself. The second takeaway I would say is kids and families that you work with are infinitely patient and forgiving. If you mess up, if you do something that doesn't work out, that's okay. Patients appreciate that you're in this trying to learn as well, and families are appreciating that you're in this to learn and may not have all the answers, and they're more than willing to work with you. So I'm going to hand it off to Michelle.
Thanks. And so I think there's a bit of a theme among our takeaways, and for me, it was that being kind to yourself and your clients during the transition, definitely learning to laugh at yourself, but also being really confident in your therapeutic skills. That's what you're bringing to a new medium. And then with respect to the medium, ask others to point out what will make it better for you. But definitely just pressing in and leaning into the good therapeutic skills that you bring to the children, youth, and their families.
I want to thank all of these exceptional panelists that we've brought together today. You'll notice that at the very beginning, there was a slider that described all of the skills and expertise that each of the panelists has brought to the discussion today. We didn't have time to go through everybody's credentials and their experiences, but it's so clear to me, I'm sure it's all clear to all of you, how much collective wisdom we were all able to glean from this session today. We just want to thank you so much for sharing your time with us. I think the tools and the advice and the suggestions that you shared with us are super helpful. There's been also a lot of chat in the chat room about specifics, and so we'll be coming back to you to ask you for those, because as a reminder to folks, the recording will be available on our website, and I believe Tracy is also going to email that out to folks. We'll also be sending out frequently asked questions or a summary, some kind of resource that captures all of the different lessons learned today. We have all of the questions that the panelists have responded to, and so we'll be going back to the recording. We'll be actually capturing their responses and putting that together for you so that you have a paper copy as well. We also want to invite you to share your ongoing needs. So as Ghislaine very appropriately pointed out, we are all learning during this time, and we would encourage you to share with us your questions and your knowledge needs, and we're very happy to take the time and do as much digging as we can to find as many of the answers as possible. So we'd invite you to certainly get back in touch with us. Again, this is the audience here is both community-based child and youth mental health organizations and the folks who work within them, and school service providers as well. So Kathy and I have a long history of collaborating, as she's pointed out at the beginning of the session, and we'll be sharing this information between us consistently to make sure that we all have similar experiences to draw on. I will just remind folks that, or I'll let folks know that an evaluation will be coming into your inbox. At the center, we take evaluation very, very seriously, and we actually use that content to develop new products and resources for you to help you to do your work with kids and families. And we also use it to help us to strengthen the way that we've delivered that material. So this is the very first time I don't think I've ever delivered a session like this. I know I've never delivered a session like this for this number of people. And so we'd love to learn from you around what worked and what didn't work. And we'd love to hear in the evaluation. I know folks have been sharing in the chat box, but also in the evaluation, if you want to point to specific things that you'd like us to search out for you, please do let us know. And with that, I will turn it to Kathy for the very last word.
Thanks, Purnima. I want to echo your thanks to these wonderful panelists for sharing their time and their experience and expertise. This is so new for many of us, and I found it personally very reassuring to hear your stories of when you first started. And we're really benefiting from your lessons learned, and thank you for your humility in bringing that forward to us. I want to thank, of course, our attendees for sending in their questions ahead of time to allow us to focus a big area of work into some manageable highlights. And for the school board professionals on the line, if you have additional questions that come to you later through your board mental health leader, if we can bring those forward. And as Purnima said, we'll be working together on some next steps in terms of virtual care. So again, many thanks to everyone for being here, and we have lots to learn together going forward. Thank you.